Let's study about common pituitary tumors. Common pituitary tumors. So, pituitary tumors can be microadenoma or can be macroadenoma. What are microadenomas? Microadenoma means that the diameter will be less than 10 mm, and macroadenoma means the diameter will be more than 10 millimeter. These tumors can be functional tumors or can be non-functional tumors. Some of the functional tumors will produce more than one hormone, and the non-functional tumors may produce gonadotrophins or their glycoprotein subunit. And these non-functional tumors are found accidentally on MRI or CT examination or during an autopsy. That's why it is also known as pituitary incidentaloma. Okay, so what are some of the common pituitary tumors? First is lectotroph adenoma, somatotroph adenoma, thyrotroph adenoma, corticotroph adenoma, and the last one is gonadotroph adenoma. Gonadotroph adenoma. Others that can be present as a common pituitary tumors are metastatic tumors, craniopharyngioma, pituitary carcinoma, plurihormonal or double adenoma, and the last one is MEN1, that is multiple endocrine neoplasia type 1, that includes parathyroid, 3Ps, pituitary, and pancreas. And in pituitary, mainly prolactinomas. Okay. So, what are the clinical features? Due to hypofunction by pressure on surrounding normal pituitary tissue, so pituitary adenomas can be presented with hypopituitism due to pressure on normal pituitary tissue. Other can be due to involvement of neighboring structure. If there is involvement of dura, then there will be headache, which is the commonest feature. If there is involvement of optic chiasma, optic nerve or tract, then there will be visual field defects, loss of acuity, and optic atrophy. If there is involvement of cavernous sinus contain third, fourth, and sixth nerve, so there will be palsies of these nerve, which will result in diplopia, strabismus, and facial numbness. Next is if there is involvement of hypothalamus, there will be obesity, disturbance of ANS function like sleep, thirst, appetite, temperature regulation, and diabetes insipidus. And miscellaneous anosmia. Anosmia is frontal lobe involvement. They can be headache, vomiting, papillary edema due to intracranial tension. Occasionally there can be bleeding into tumor, so that is pituitary apoplexy. Due to secretion of hormones, they can be due to growth hormone there will be acromegaly or gigantism. Due to prolactin there will be amenorrhea, impotence, and occasionally galactorrhea. And if there is production of ACTH, that will result in Cushing syndrome. And if there is TSS secretion, then there is hyperthyroidism. What are the investigation that we can do? So the investigation that we can perform is plain radiograph of pituitary fossa. What are the features that can be seen? There can be enlargement of sella turcica. There can be erosion of clinoid processes. There can be suprasellar calcification. There can be double floor of sella. So these are the features that will be present in plain radiograph of pituitary fossa. There will be enlargement of sella turcica, erosion of clinoid process, suprasellar calcification, and double floor sella. On CT scan, contrast enhancement, that is more sensitive than MRI for bony erosion and presence of calcification. We can do MRI before and after gadolinium. This is more sensitive than CT scan for soft tissue tumor. For soft tissue tumor, we will do MRI before and after gadolinium. And for bony erosions and calcification, CT scan is more preferred. For visual field, we can do visual field floating if there is involvement of optic chiasma. If there is bitemporal hemianopia, that means there is involvement of optic chiasma, pressure effect on optic chiasma. If there is unilateral loss of acuity or scotoma, then that means optic nerve is involved. And if there is homonymous hemianopia, that means optic tract is involved. Let's do the functional assessment of gland. How we will do the functional assessment? By hormonal assays. Hormonal assays like prolactin, insulin like growth factor 1, 24-hour urinary cortisol, LH, FSH, and thyroid function test. What is the treatment of pituitary tumors? Except for prolactinomas, other pituitary tumors we will do surgery as a first line treatment. In prolactinomas we give the dopamine agonist like bromocriptine, cabergoline. This will shrink the tumor and possibly avoid the surgery. We can give the somatostatin analogues like octreotide, pasireotide, and lanreotide for growth hormone producing tumors. And we can also use growth hormone receptor antagonist, that is pegoisomend. Next we can do transsphenoidal or transfrontal surgery. Next we can do radiotherapy to suppress the growth of the tumor, and it will reduce the secretory capacity of the tumor. How we can do the radiotherapy? This can be achieved by external radiotherapy, that is fractionated radiotherapy, or we can do implantation of yttrium in pituitary fossa, or we can use gamma knife or modified linear accelerator. Gamma knife will do the precise delivery of large single and high energy dose to tumor under stereotactic surgery. So this is all about the pituitary tumors, the common pituitary tumors, the clinical features, the investigations, and the treatment. Okay, thank you so much for watching this video. Like, subscribe, and share.